As you have seen, we have an exciting presentation today titled Multidrug-Resistant Tuberculosis, the Laboratory Perspective. So we are excited to have you here. And at this point, we are privileged to have a renowned speaker. This is none other than Albert Okumu. Albert Okumu has many years of extensive experience. Specifically, he's a research scientist with a bias in medical microbiology. He's a known lab consultant in infectious diseases, specifically tuberculosis. And Albert also heads the KEMRI Tuberculosis Research Lab. That is the KEMRI Center for Global Health Research in Kisumu. And we are excited to have Albert. And I want to take this opportunity now to welcome him and to proceed. If you can hear me, Daktari, welcome, and you can proceed.
Thank you, Fred, and thank you for the honors and the privilege to share with us, all of us, new information, old information, relevant information as you may want to look at it. And we were going to learn together in this field of infectious diseases with a bias on tuberculosis that we are going to talk about today. And once more, thank you for the audience that have joined and those that are joining so that we may be able to share and learn much about TB. Thank you again for the beautiful intros. And again, as we delve into this very, very important topic of multidrug-resistant tuberculosis in this era where antibiotic resistance is the in thing when you look at the various disease areas that are around us. And of course, having gone through the last 2, 3, 4 years on COVID, the impact that that did have on TB management and TB infections. So this is very, very important. So our topic, as you mentioned, is sorry, Fred, I don't seem to be having control of my movement of my slides.
So for those of us who are joining now, we want to welcome you. Doctor, are you able to move them now?
Yes.
Great. Yeah, it's very clear. Proceed.
Okay. Thank you. So our premise of discussion will be around objectives, a little bit about the facts that we should know globally, and then also look at a little bit of Kenyan profiles, talk a little bit more of science around the pathogenesis, and then delve deeper into the role of the lab. That then will give us the perspective of laboratory in terms of diagnosis, classifications, and what will be the take-home messages from a laboratory point of view. The broad objective that we're looking at is how would somebody working in a lab identify multidrug-resistant TB? How would you talk to people about it? What would you say about it? Or what is the information that you may want to share around drug-resistant tuberculosis? And then also, what kind of knowledge or information do we have as a people working in the lab on the epidemiological aspects of drug-resistant TB? And then more home would be what are some of the laboratory diagnostics that we have. We may not talk about all of them because there are several, many from cultures to immunological to PCR based. So we'll talk about a few that we know we can routinely associate with in our various lives as laboratory people. So first things first, so basic definition of what TB is. I know in the audience, we may be able to talk about what TB is and we may define it in the best way we can. But basically, for a layman's point of view, we'll just say that TB is tuberculosis is a disease that is caused by a bacteria, which we all know the bacteria as Mycobacterium tuberculosis. And if you delve deeper, you'll be able to say it's not only Mycobacterium tuberculosis, but it's a Mycobacterium tuberculosis complex. And even as you go granular, you may be having, a little bit of information that about this complex, which other strains comprise the complex that therefore transmit to us tuberculosis. And largely, it's been recognized that it's a disease that affects individuals whose immunity has been hampered or affected or reduced. And because we are told that everybody does have TB in a latency stage, but when your immunity does get affected, then the bacteria gets activated, as we will see in the pathogenesis, and therefore when it gets activated, you may be able to feel sick. And when you feel sick, if you don't get treatment quickly or rapidly, then you'll be a source of transmission or infection to the rest of the people around you. And one thing would lead to another. And basically, we know TB does lead to death. And that's why we definitely want to really talk about how then we can be able to prevent transmissions coming out after we've been able to diagnose and identify TB. So basically it's just a disease that we know is caused by this very hard and tough bacteria, Mycobacterium tuberculosis. Some of numbers, it's always important to have numbers in discussions, and WHO puts certain numbers here. This may not be current because I think the 2024 report has come out. But we are told that a huge number of people died globally, 1.25 million, just dying out of the TB disease. So that's really, really shows why it's important to talk about TB and see how best we can manage our people, our communities, our colleagues, our families, our community, wherever we come from, to be able to be aware of TB and how to protect or prevent and treat. And we are told that by 2023, we are told that 410 people developed multidrug, what we're talking about today. So 1.25 million globally dying of TB, and then another substantial number of around 410, probably last year and this year, probably the number has gone up. If we could get access to the data, we would be able to see that. But this is very concerning, very, very concerning that a huge number of people are getting sick. And when they have multidrug, that's even worse, because then that becomes to a different level of management, as opposed to if they only had TB, the normal, what we'd call, in quotes, normal TB. And these figures of 410 we are seeing from the report I had was around 2022, and we're in 2025. So it could be different. We are told that although countries are trying to manage patients who develop MDR-TB or rifampicin-resistant TB, the movement towards managing them is a little bit slow. And therefore, a lot of efforts. People need to put a lot of efforts. And there, when we talk about people, we talk about government, ministry concerned with TB management, and specifically the programs within the ministry. And I'm referring to probably the HIV and the TB programs, because HIV and TB, they do go hand in hand in so far as these infections are so much concerned. And when, there seems to be slow improvement, it really shows that there will be an increase or upsurge in people getting more sick, and they are becoming sicker with a resistance that then hampers even the gains that have been made. So what is MDR-TB? Basically, we define MDR-TB as that particular disease status where an individual is termed to be resistant to two primary drugs, very, very important drugs. These primary drugs are among the many drugs given to people identified or diagnosed with TB for the first time, which I'd called earlier normal TB. And these two important drugs, one is rifampicin and the other one is isoniazid. So when you're resistant to these two primary drugs, then that's a problem. And you must be resistant to these two drugs at the same time. That's when you qualify to be referred to as a multi-drug. Of course, you may have several other resistance to other drugs, which is put in the primary pool, group A. And that, because of treatment of TB, you'll have like 4 drugs given to you at one go. We have isoniazid, rifampicin, ethambutol, and probably pyrazinamide. Those are 4 drugs. But for you to be termed as multi-drug, you've got to have these 2 among the many resistance that you have. And we will see the various definitions of the various resistant patterns that we talk about. So that is very, very important to understand what multi-drug resistant TB is. So our country also prides itself, like the whole world, in trying to adopt the end TB strategy. And as one of the strategic development, sustainable development goals of 2030, 2025, there is a push towards elimination of TB. Of course, we are not yet there yet, but we can see that there's a lot of movement towards that direction. Whether we will be able to attain this, it's a discussion for another day. But at least we may be able to see whether the country will work towards achieving this. And there are several things that the country needs to put together in line with what WHO says as the key pillars that they would want each and every country with a TB program, Minister of Health under TB programs trying to do. They're having a zero, with a broader vision, when they say zero TB, but they expect that countries will be able to integrate patient care in facilities so that you don't have people put aside as TB alone, but you can even go to hospital and get your TB diagnosis, TB testing clinics, doing HIV, doing malaria. People get those services integrated. And then the government also developing policies that it should be able to align itself towards TB management. And then there should be a lot of work going out into the community intensive case finding, a lot of researches that we should be able to inform innovations that are coming out of diagnostics and all these kind of spheres to be able to try achieve the target of the end TB strategy of the 2035. Whether that will bear fruit, I think ours is to work and do what we think we can be able to do to show that we are in line or in sync with trying to achieve the targets that has been set by WHO and adopted by countries worldwide. A little bit of demographics, epidemiological aspects here. We see, this is a WHO map that I picked from 2022, just showing areas where we have MDR. Kenya, which is right there in the middle of Africa, is shaded white, showing that there was no clear estimate at the time of what is the population of people with MDR-TB. But of important is you can see there's a lot of XDR-TB cases reported in Europe, all the way to Southern America. And around the yellow part is Russia, some Eastern Europe having a lot of this TB, and even Southeast Asia. So it's concerning how MDR-TB is spread across the world. And I'm glad that our national TB program, I know some members are here, they've recently did drug-resistant surveillance, and probably from that report, we'll be able to know what is our prevalence, because that will be the latest report that we are waiting for to come out of that survey that has been done recently in our country. These are just incident cases of a number of people with MDRs and the people that are reported to be, being infected. At least now we see Kenya, with the population there is approximately about 1,000. These are updates around 2022 by WHO, and still you can see Southeast Asia leading with a lot of this. So this shows us that there's a lot of TB around Asia. And interestingly, if you look at sub-Saharan Africa, there's a lot of TB, whereas in the northern part, which we could call the Arab North, there's little or no TB as much. And then you go all the way to Southeast Asia, down to Indonesia, up to India, all those regions we could see, and China, we are seeing there's a lot of TB. And also look at Russia. Eastern Europe seems to be having a lot of TB. So TB is a global phenomenon. The America seems to have little or no. Canada seems to be clear over there. Doesn't mean necessarily that there's no TB in those countries, but at least the numbers could be negligible, and that's why they're not there. When we look at the prevalence in Africa right now, and we could see Kenya also shows a lot of some prevalence ranging between 0 to about 7% prevalence of DRTB. And you can see the big country right in the middle of Africa, that's the DR Congo, seems there's no report. So that tells you that there's a lot of challenges in DR Congo in terms of either accessing services or getting these services documented or getting these cases documented. That's something that somebody can be able to see and work out and see what's really happening. And then also go down south. There's a lot of issue. When you come to West Africa, there's a lot of TB, as you can see. Then you go to the East Africa, around there, Kenya, Tanzania, all the way to the Madagascar, in the islands there. A lot of TB, even to the Horn of Africa, around Somalia, Eritrea, a lot of TB, Ethiopia, a lot of TB on that, and even Sudan shows some TB in existence as well. I got this from WHO, the latest report from 2025, showing the Kenyan profile, coming home and seeing by 2023, estimated population we had was about 55 million. And out of the 55 million, what is important here for us to look at is life expectancy. Whether we live up to 67 years, that's something else. But look at the deaths in the various categories, which is so concerning. And also look at the health facility availability in our country and the populations that are attached to those facilities. And then if you look at the national budget that is posted, around 7-point-something% of the national budget. So if that is the budget that the country provides to handle health, and the health has various components, not only TB. So you can imagine what amount of resources that the country does put into TB. No wonder the country gets supported by external donors and funders to be able to manage TB. Otherwise, it will be a very tall challenge on the country to be able to manage TB for that matter. Nevertheless, the country does get support from WHO, gets support from Global Fund, gets support from previously used to get support from USAID and other USG bodies and various funders, but we all know the current scenarios that exist right now in terms of supports that are coming from the USG aspects. Now, coming to little basics, we are able to share with you trends from 2015, how we have been able to capture some of these disease, of DRTB cases in our country, and we can see a steady rise, both with drug resistance among adults and also drug resistance among pediatrics. Back, we may not have data for the previous years as of when we are having for the pediatrics, but there's a steady rise. And more concerning is a rise in the pediatrics. So you may ask yourself, is it that we are now seeing more cases among children, or we never used to do diagnosis for children, and therefore that's why the cases were low? Or, questions are abound about that from 2006 all the way to 2022. But there's a rise, and that rise should be able to show us that there's need to up our game in terms of managing and finding these cases and putting them into treatment. The more cases you have for DRTB, the bigger the problem the country is going to face. So the sooner we get these cases sorted, the better for the country. So you could see the trend, very, very concerning. There are years that, like 2020, I think this is 2020, 2019, 2020, around the time that COVID was there, and you could see the high stakes in the TB that went up. So I do not know whether we stopped doing TB and concentrated on COVID cases, or COVID went down and then we went back to diagnosing TB cases, and therefore that's why the numbers went up. Those are very productive research areas that we can be able to pursue if interested. And again, this is just showing us all these cases, all the various resistant patterns that we have, whether it's rifampicin, whether it's isoniazid, whether it's the MDR cases. The trend just shows you, and this is not very nice, because we ought to get a very good graph showing us that there's either a decline or a steady to a decline, which then will show that the efforts that are being put out there really to manage the cases that we are looking at are bearing fruits. Nevertheless, it's important to note that regardless of the efforts that are being done, something is being done, and cases are going down or coming up, showing that there's need to be movement of activities that we need to do. But it's important to note the various drugs that are being offered, are they supporting management of TB? Because out of this, we'll be able to know which drug has a higher resistance within the population. Should we be able to withdraw this drug off to circulation? These are the areas of operations research that we give our patients this line of treatment, but majority of them are resisting, are becoming resistant. So do we need to continue, or what do we need to do to be able to get these patients treated and improve? Now we want to look at briefly about the pathogenesis of resistance, because that's what we're talking about today. And we all know that TB bacilli are inhaled or transmitted from one individual that has TB, and if they're in close proximity or environment or whatever, then the other person will be able to inhale this bacilli. And if they do inhale the bacilli will get, themselves to their various routes of movement into the body and go to the alveolar sacs of the individuals in the lungs. And when they get there, then some immunity or immune reactions activities will be, affected in the body. The macrophages will be put into action to try and absorb these foreign bodies that have come into place. And we will have the macrophages surrounding this bacilli, and everything will happen. And two things may happen. One, the macrophages will be able to subdue the bacilli in the body. And when they subdue the bacilli in the body, then you'll remain in a latent stage. And that's why I said everybody is normal until the immunity gets down. But another thing can happen, that when the macrophages come to fight the bacilli that gets into the body, they may fail to do so. And the bacilli may take, responsibility of now doing what they need to do. And then necrosis of the granulomas that are formed, and, many replications of bacilli will happen into this individual, and they become sick. And they become active. And when they become active, that's when people go down with TB. They are sick and they have to get treatment, and so on and so forth. And if they don't get treatment, then they'll become agents of transmission as well. and therefore many more people get infected, and vice versa. So when that does happen, then we move to the next stage, where the mutations will happen. The bacteria now, therefore, in itself, when it's being fought by macrophages and everything, it will also try to defend itself to survive. And therefore, it has its enzymes, it has its plasmids, it has also that are able to, prevent the targets where the drugs will be able to mount themselves, and therefore prevent it from accessing the bacteria to kill it. So when the drug fails to access the bacteria itself, that then brings a problem. And then the enzymes that the bacteria does have will be able to change, modify, the areas where the drugs could be able to occupy, and the plasmids will produce copies of the newly tough bacteria that is not able to be affected by the drugs, that will be able to mount on it. And the bacteria then will continue, the mutations will happen, will happen a lot, and more bacteria will be produced. And when they produce with the efflux of the bacteria, then these mutants will be spread out of the bacteria, out of the cells, and out of the, where they were lodged in, and go back to the same movement of going back to the lungs, to the airways, and therefore an individual will be resistant. But now, not only will they be resistant, but will also be spreading more and more of this bacilli. So this mechanism causes serious problem to the individual, because the mutations that will happen in the foreign proteins of the bacteria will now, reduce the antibiotic entry into the bacteria. And then the enzymes that I said will either degrade or will alter, and then causes all this to happen. And then disruptions of the bindings of antibiotics with the bacteria will not happen, and thus mutations will occur. So if you start bombarding an individual with the same drug that you had put there the first time, nothing will happen, and the patient will continue worsening and worsening. And that's why you start somebody in treatment, and they will be okay for probably 1 or 2 weeks, and thereafter they become worse. Or even after a month, or even after 2 months, they become worse. And you may ask yourself, what would be the possible causes of developing MDR resistance? Many reasons could abound, but I put a few here that we can also talk about. It could be somebody was using the medication inappropriately. So like I said in my other slides, that probably you're prescribed to have 4 drugs and to treat the TB disease. But because you feel that is too much pill burden, you take 2 and say, I will take 2 in the morning, then the other 2 I'll take in the afternoon, something like that. You take them inappropriately. That does cause a problem. And I think that would be one way where resistance will develop. Probably some of the medicines that we are taking, I know we have what we call original, generic, and what have you. So that kind of formulations, sometimes you may have a drug that the formula for pharmacy people, they will say the pharmacokinetics and what have you, but the formulations may not be the formulations that are required, and thus then predispose an individual to resistance, as we say. So we're talking about poor quality anti-TB. And then probably there will be interruptions of treatment. Somebody may be able to start feeling better today. The treatment, maybe they are in intensive phase, probably for 2 weeks or a month, whatever, given by the clinicians, and they feel better in a week's time, and then they stop. Or they don't stop voluntarily. Probably there are no medicines, like we know in our country. Today there are drugs, tomorrow there are no drugs. Then you're told you start with this for 1 week. When 1 week is over, please come back for more, so that you share. Then when you come back that week, there's no drug. So lots of reasons why you can have interruptions of treatment, and that does cause a problem. There are areas or countries or places where the TB program doesn't reach people, and therefore these drugs are not even there. So then individuals may also just develop these kind of things, and probably there are no standardized guidelines. Somebody decides on which is the best treatment that I need to give, or there's nobody following up on the treatment guidelines that have been provided by the country, or inefficient supervision coming from people responsible to do this job, and following up and saying whether this thing is done appropriately or not. those are some of the challenges that we can, predispose individuals to this. And also, when you fail to suspect somebody to be having MDR-TB, you've put them on treatment month 1, month 2, and I think the national program provides information that when somebody has been put on treatment, the normal TB codes, after 1 month or 2 months, you must do a monitoring test. If you feel there is no response, then you need to suspect potential MDR. So if that doesn't happen, then you may end up having people continuously being put on treatment, disregarding the possibility or potentiality of them being multi-drug resistant, and that provides the bacteria more time to spread and even cause the problems that it does cause in the community. So classification of bacteria of the drug resistance, we have various ways of classifying them, but just a few that I didn't mention. Some are being classified, the drug resistance are being classified based on the resistance we have. Like, for example, you can have somebody, classified as presumptive multi-drug. This is somebody who is suspected to be having TB because he's not responding, or he or she not responding to the first line of treatment. You can have mono-drug resistance, that's somebody found resistant to only one aspect of the drug that is given the treatment. Multi-drug, I did mention that must be 2 of the 2 critical drugs, isoniazid and rifampicin. And then pre-XDR, 1 fluoroquinolone now included in the mix of iso and the rifampicin, and then extensively is 1 fluoroquinolone plus an injectable drugs in the mix. So that is just based on the drug themselves. Then the people can also be referred to a drug resistant based on the patient type. And patient types are people like those who refer to relapses. These are potentially people who might have gotten full treatment of the disease and got, and documented as, treated or cured or whatever. But later on, probably several months down the line, they come back sick. When diagnosed of TB, they are found to be TB. There are those that are, when they get better, they go away. And then after 1 or 2 months, they come back. We call them return after loss of follow-up. And those who are either on treatment but are not responding, like I said, on month 2 follow-up, not responding, month 5 follow-up, not responding, all those kind of people. Then we have also resistance classified based on the anatomical, region where the TB disease or TB bacilli will be found. There are those that could be found from within the pulmonary, excluding the pleural effusion area. This is and then we have the extrapulmonary, other places other than the lungs. They can have people of the TB adenitis, people with the skin TB or whatever part of TB, but outside of the lungs. So that is also another classification, the way we can classify drug resistant. And another group among the many that are left, that is HIV status. We can have people when you have TB and you have HIV, we refer to you as HIV TB co-infected, TB HIV co-infected, whichever way you want to look at it. And then those, we can also have individuals who classify them as HIV negative but having TB. And then we have people with TB, we do not know their HIV status as well. So that's about the preliminary. Now we go into lab diagnostics, where we look at the perspective. Now we've known what multi-drug is, and now as a lab person, how then do you support multi-drug resistant TB management in your own area of influence? And WHO categorically states that we can identify an individual and term them as having TB, not only multi-drug, but having TB when we have bacteriological confirmation. And bacterial confirmation must be done in the lab. You've got to do a smear, you've got to do a molecular, you've got to do a culture. When you find them, when you find DNA, you find the smear, you find the culture, then you authoritatively can say that an individual has TB. This means that somebody can be done X-ray, and the X-ray will be suggestive. And that's why X-ray results are always referred to as suggestive, right? And a clinician will look at you and they will, say that given the signs and symptoms and what have you, go to the lab and do this. And when the lab says you don't have TB, based on the test that they've done, you don't have TB. Clinician will not say that you have TB. They will only say clinical decision suggestive of TB. Then they can start you on treatment. It's allowed. But WHO says for you to confirm somebody is having TB, lab is to be involved. So very, very important to consider that lab is important. And there are various ways of identifying somebody having TB and the resistance, as we are going to look briefly down here. And so lab staff here, you play a critical role, recognized role in confirmation of an individual having TB or multidrug-resistant TB. So what are some of the roles that we play as people? There are many roles, but I only picked 4. And number 1 is confirming that a patient, an individual, has TB. So you can confirm somebody has TB very depending on whatever technique or test out there that you've got to do. Like I mentioned, smear microscopy, whether it's ZN, whether it's a fluorescent microscopy, LED, whatever. Gene expert, TrueNut, TB lab, culture, LJ, provided you can be able to confirm that, that's your role. So we need to do our roles perfectly okay. When we have slides to be done, sputum samples have been brought, or whatever specimen that has been brought. Remember, we can test TB from various specimens that we have. Right now, the country introduced the use of stool as well. So we can do sputum, we can do CSF, we can do urine, we can do pleural effusion, you name it. Swabs, we can take swabs, we can take aspirates, So that's role number 1. Role number 2, we support MDR by doing monitoring. And that's why we have labs out there in the field. We have monitoring we can only do using microscopy. You do monitoring, you can send samples for culture, but those with culture facilities are able to do culture as well. We are, as a lab, supporting management of MDR when we do that role. Number 3, which is very, very important, is to support surveillance. And the work that we do every single time when we test for TB, when there is an intensive case, outreaches, screenings, I normally see coming to a lab that, we have this activity, we are going out to prisons, mass screen, getting all the sputum from people, or we are going to schools, so we are having a campaign, or what TB Day is coming, so we want to do all those fall into play into surveillance for TB, and also organize survey, like what I did mention that the TB program did just recently, all those surveys. So the lab is supposed to support that, and when it does support that, it informs a lot, it provides a lot of information to the country as well, to be able to know what is the direction that we need to take. We see probably in Western Kenya, there's a lot of rifampicin resistance. So what do we do? Or in northeastern part of our country, there's a lot of isoniazid resistance, and vice versa. So surveillance is key and critical, and is a critical role that we do as a lab. Then another important role is research, which I did mention earlier in the other slides, that when operations research are being done, whether and samples are involved, they will get themselves, the samples will get to the lab. Or clinical trials are being done, new drugs are supposed to be implemented, and these new drugs have to be tested. Or new equipment have been developed, and you desire to use them, you must validate them. And so the lab plays that critical role, so that we are able to provide accurate, reliable information that the country can therefore use for implementation. Some of these researchers that come out of our labs are very good for global policy change, global, national policy formulations, if you will. Recently, we did a study, and probably it's under consideration. We did a study where we were pulling specimen together. You are having, right now we have one gene expert cartridge for one patient. One gene expert cartridge for one patient. But the study that we did, we were having one cartridge, but 4 different patients. So you take 4 samples, do what you need to do, and put them in one cartridge and run. So if that cartridge turns out negative, all the 4 are negative, so you don't use other cartridges, you're saving. But in the event that that one cartridge becomes positive, then it forces you to run individual tests for the 4. So those are some of the areas that the lab can play a role to try and help. And assuming that we had 20 people and you group them into 5 cartridges and they're all negative, you imagine you'll have saved almost 15 other cartridges and time notwithstanding. But if they're all dotted with positivity, then you'll have to run them again. So research is very, very vital role that the lab does play. And what is required for a lab to play that role? The lab must have an adequate infrastructure to be able to do this and to do the level and to the limit that you're able to do. So if you're a lab that is basically doing microscopy and you can either FM or ZN, you must be equipped to do that. Number two, you must have human resources to be able to accomplish that as well, so that patients do not wait for long for whatever results that they ought to get, because we know the challenges in delayed results. Delays treatment, then increases transmission, then increases other disease conditions to the rest of the people. And then the lab also must also put in place adequate measures for collection, transportation, and relevant networkings to have the specimens done appropriately. Then the lab responsible, depending on the level of your category, you need to know what tests are suitable for you to do, or what tests are you cut out to do, so that you do not chew what you're not able to do. And then when you do this, you must ensure that you have your EQA systems in place, EQA, IQC, all those put together as QMS. Of course, we need to have data management systems in place. I know we have LIMS of various forms and functions, but this is just but a brief points to consider when you want to have a functional lab to be able to support in their diagnostics. There could be many, many more, but ultimately, these factors you must be able to have and be ready when you're asked to conduct research, either for clinical trials, vaccine trials, or just operations research. For whatever reason, the lab should be able to be cut out if it's ready to do that for formulation. I got this picture from the MOH report. I was just looking at how the country has molecular support towards doing DR surveillance. And you could see there's a lot of gene experts dotted across the country, a lot of TB labs dotted across the country, so that it means the government is really alive to the fact that we need to do testing. And WHO recently stated that gene expert or molecular test is the primary diagnostic test for TB. So this goes in line with that recommendation, so that we do not lag behind in the recommendations, as it were. So basic techniques that I took time to look at, which we know are existing in our routine setup, and some that we should aspire to have. Start off with ZN, which has been over 100 years old, and we know ZN has been there and will still be there. This is very useful in monitoring patients right at the grassroots, even before specimens are shipped to referral facilities for cultures and other advanced technologies. And only challenges is the limit of detection, which is quite low, but it does offer solutions at the peripheral facilities. And we all know from members here, they know that in the facilities where they've been working, sometimes when gene expert is not available, the equipment is broken down, supplies ain't available. They usually told you not just send somebody home. As you send this to culture, wherever site you're sending it, you may be able to offer them a ZN smear. FM, of course, we also know about it, and that's the same as ZN. Some other facilities, we call it LED or whatever, but I think it has a little bit of higher sensitivities and specificity more than the ZN that we are using currently. Then we have the cultures. So LJ, which has been old, also does its functions very well. And we should know that WHO recognizes culture as the gold standard for TB diagnostics. So it's important that we have it. I know few facilities in the country does have it, but it provides a definitive confirmation of the presence of TB, and that's why it's one of the gold standard. Also, it's able to do what it's supposed to do and increases its limit of detection. Then we have the recent culture method, we call it liquid culture. Also very, very good. And I think this is quite a little bit expensive as compared to the LJ one. But it's also good. Well, LJ lasts between 56 to 60 days to get a full report of a negative sample. Midget does have between 42 to 45 days. So slightly improves with a 2 weeks more, 2 weeks less than the LJ. So it's something that we need. And this grows, in this equipment very well, which does not have external, challenges that it can have, except power requirements are very, very important for doing cultures, whether it's solid or liquid. And then we have molecular assays as well that we know of and we can sing about. We have GeneXpert, which has been a talk since 2010 when WHO approved of it. In country, I think we started implementing this around 2010, 2012, 2013 period. And I think now this has been spread tremendously across the country with a very good limit to detection, 131 colony forming units per ml of sputum sample. And advantage of GeneXpert, we all know it does rifampicin, but now another GeneXpert that has come, which we are calling it Color 10 or wherever, that is able to do isoniazid resistance, and then it's also able to do second drug resistance. So that is advancement in technology. So this was initial, but now there are changes that have come in, and I think we are proud to have as many technologies that they can support our activities. Then we have the TrueNut, which also came recently, also supports activities just as GeneXpert does, and also scientists are not sleeping. They're continuously looking for things that could make it better and better. Ultimately, I think the goal is to have a POC that a patient can be able to get the feedback right immediately. When I began working, I think the early days, doing an HIV test used to take several days or weeks or even months. But right now, because of technology, you just sit with somebody and they get to know their status, in the next 5 or so or less minutes. So that should be the goal that we should be looking at. Then we have the line probe assays. We all know LPS, also very, very good. Does both rifampicin resistant, isoniazid resistance, and also another form of LP that can do second line drugs as well is in the market and is in play. And I think it's been employed by the National TB Program right now in the various labs that are running the test. We have this TB lamp as well that is also good. And it's being said this is just good for primary testing. It's a molecular device, yes, but it's good for primary testing, which does not give us the other options of the resistances. But it's fairer as compared to the other expert and the TrueNuts as well. Then there's this one that we haven't implemented yet, but like I said, things that we need to look at and things that we need to consider. This has we call it multiplex CGene. So it's able to detect both TB and NTM. And I know many people are now asking questions about NTM. And this molecular device is able to do that and help us know differentiate between MDR, TB, and NTM as well. And then the big one, whole genome sequencing. It's available, may not be routinely available in country, but is available. And I think we will get to see, once this is installed at the National Reference Lab, capacity to have a whole genome sequencing done. That will be a game changer in country. So as there's a movement in technology advancement that then will help our country to also compete with the rest insofar as diagnostics of DRTB is concerned. We all know whole genome sequencing can be done for whatever pathogen that we want, but now being that I'm speaking from TB, I'm looking at how can we, in the TB space as well, edge our space and also do whole genome sequencing to be able to assist where it can and, bring out all those strains the species clearly and say which species and which strains are, affecting us from Kisumu to Mandera, from wherever, so that we'll be able to know that this strain is foreign. This one has come from Ethiopia, and be able to see how to do that. So this, in the DRS that I think I did mention has been done, there will be a report that indicates that this test was actually done to the survey participants. This slide was just showing us the levels at the difference of identification of this, which one detects, which one requires more colony forming units and which one requires less to be able to detect the bacilli that we have. And then we have what we could term as POCs, we call them immunological tests. Urine lamb, so there are various forms. There's urine lamb, there's TB lamb, there's LF lamb, all those lambs, they're the same. And also, they're just targeting the immunogenic lipopolysaccharide that is produced by the bacteria. It is, shed off by a bacteria from a bacterial cell when the bacterial cell degenerates. And this protein is present in urine. So it is this protein that then combines with the lamb kit to give us the color formation, just like you do for pregnancy test, or even the one that you do for HIV test and stuff like that. And we are told that this test has always been preferred for people, HIV positive individuals, but with very low immune count, CD4 less than 100 cells per minute. Then we have the ELISAs, we have the what we call the QFT or interferon gammas that detects two proteins of importance, ESAT6 and CFP10 proteins in the blood system. So this normally is used for people studies, preferably those that want vaccine studies. And then it will tell us about the latencies of individuals and stuff like that. So very, very important also to have this kind of test. And then a new one we call the gold nanoparticles, which is a PCR mechanism that then they have ferromatic gold particles combine with the with the target zones of the MTB bacteria in a specimen. So this has not been implemented in our country, but it's something that we need to look at. Of course, somebody may look at gold and say they will not do the test, they will take the gold and sell, but that will be not right. But it's a very unique kind of test that other countries are still validating and looking forward. There are few people that have been able to do that. Then, as I come to close, we know that lab plays a critical role in MDR TB management, and therefore there are certain lab procedures that must be done towards monitoring patients who have drug resistance. I just listed some of those tests that you must consider when you have patients managed under drug resistance. So we have microscopy, culture, and the blood works that you people have been doing out there in the field. Of course, it's important to know about the viral load, CD4 status. Probably Kenya has stopped doing CD4 testing and concentrating on viral load. That's okay. We must screen our people. We must do pregnancy tests because of the drugs these patients are having. Chest x-rays and all those kind of stuff are important in monitoring. Somebody might have wanted to know what are the relative costs of doing these tests if you want to manage. I'll put in a few costs there. They're just ranges. And this may vary from country to country, or from lab to lab, depending on how they access whatever it is that they need. Point to note is the patient necessarily doesn't pay these costs. And that's why I say the Ministry of Health, the National TB Program, always provide all this requisite support to have our patients get tested. So it is my call that we may be able to use or utilize the services the ministry provides effectively and efficiently for the benefit of our patients. Finally, my last slide is TB disease is a continuously a public health problem, so we need to be vigilant. And DRTB is on the rise, and being that they are on the rise, mutations are gradual. So we need to take care and treat as early as we can. We need all of us to be able to manage drug resistance, and we need to avail lab services appropriately. And therefore, as WHO recommends, lab testing as a gold standard, we need to make our labs do what we are supposed to do. And also, we need to consider the various techniques that we are open up to, and also identify the kind of TB diseases that we have. So it's good to know what kind of TB or their TB that an individual has, because probably whichever disease you have, the drug-resistant TB you have will attract a different kind of treatment therapy. So it's good to know the kind of TB that you have. Otherwise, I would want to say thank you so much for time to be able to share, and back to you, Fred.
Thank you so much, Dr. This was so excellent, where you are very audible and slides were very clear, a bit packed, and a lot of positive comments from all the participants here. And we want to appreciate your presentation. It's very great. It's really eye-opening, and it's just the beginning of many conversations that we need to have as people who support the lab. So, Dr. there are a couple of questions. There are so many, and we will try and address the ones that we can. And this is to all the members who are listening or who are following this. If you still have a question that you feel you need to ask, you can kindly just write to us through the Q&A section. But up to now, we receive a lot of feedback. Dr. Gatua from Kenyatta teaching, this is KU. Yes, Dr. Gatua, thank you for the accolades to Dr. Dr. Helen Ogola, this is the CMLC Caucus chairperson, is saying, thank you, my senior, for bringing clearly the lab perspective in MDR-TB. God bless you. So there are so many, but Dr. if you allow me, we'll get into a few questions. And the first one is from Dorcas Kemunto. I've also seen Amos Kwambai asking the same question. And they're asking whether we can do gene expert for follow-up. I think in practice we are doing we are doing microscopy. So maybe you can just maybe start with that as the first one.
Thank you. That's a great question. Yeah, I get to hear that a lot. We normally say that follow-up, when we're doing follow-up, we are concerned with having the bacteria going down in terms of either improvement by the patient. And we can only know that we are having bacteria going down when we see, when we can quantify the number of bacteria that we have now vis-a-vis what we had when we were starting. Gene Expert may not tell us that much, because Gene Expert is a molecular text, is concerned with the DNA. So even if somebody had bacteria that are dead, Gene Expert will still, show positivity. But if you do smear, you'll be able to see that, yes, there's improvement, because you are 3+ probably at the start, and now you are at 1+. So that shows a change. In HIV, you'll call it seroconversion. And when we do culture, it's better, because then culture will only grow live bacteria. So if you have live bacteria in your specimen, then you'll be able to see and know whether you are doing well or not. So for now, I think we will hold off using Gene Expert for follow-up, but rather use Gene Expert for presumptive, for suspected cases of those that are not improving. I don't know that I'm confusing you. So for example, if you did Gene Expert to diagnose, Gene Expert is for diagnostic. So you use Gene Expert for diagnosing a patient, and then you start them on treatment. And then when month 1 comes, you just do smear and culture, possibly. Month 2, you do smear and culture. But if month 2, culture and smear does not show some positive signs, I mean, you feel, no, something's not happening, then you are allowed to do Gene Expert, because now you're considering resistance. And that would then be, you can use Gene Expert to test whether you're assuming there will be a presumptive case coming out of that particular patient. I hope I was able to clear that.
Yeah, that's clear and perfectly answered, Daktari. So I'll move to the next one, to who is Amos Kwambai. And I think this question is coming up from many people, so maybe I can just read. So Amos is asking, the first one is, can unpasteurized milk or unboiled milk cause TB? And then Amos is also asking on the issue of sensitivity and specificity of TB lamb. And maybe just to add more meat, this is from Christine Nyawanda. What's the difference between TB lamb and urine lamb? And is this true that urine lamb is only positive in HIV patients? So, Daktari, this issue of TB lamb, maybe you can just address it. And maybe I can read the last one on TB lamb. Wilfred Gatua, is urine lamb test specific for patients with HIV? So maybe you can just see how to answer those ones.
Yeah, great questions. Great questions on TB lamb. And I think a lot of people are concerned about TB lamb, urine lamb, LF lamb. And that's why I said in my presentation, the lambs are so many. There's not, they are not different from each other. Some of these are probably names attributed to the companies that make them. If it's Alere, for example, Alere will call theirs Alere lamb, right? TB lamb. So if I may start with lamb, urine lamb, and testing for HIV positive individuals only, I think that is critical. That is very critical. When TB lamb, urine lamb, or whatever lamb was introduced, it was preferred for people having HIV because of various reasons. One of them is the inability to produce an alternative specimen that can be tested for TB. We know, and for people who have worked with TB patients for a long time, some of the HIV individuals have challenges in expectorating sputum. And therefore, urine lamb was something that was good to help salvage that scenario. Number one. Number two, if somebody had TB, probably at an advanced stage because of lowered immunity, there's a shedding of the protein, liparoabinom, whatever the long name, into the urine. And that then makes these patients potentially easy to get TB out of the urine specimen. So, and then the third reason is the manufacturers of the original lamb kits before advancement of technology, which I'm going to talk about, considered HIV individuals only at the time. But right now, there are companies that have developed fourth generation lamb kits. Some are still under research. Like my lab, we are researching on one that cuts across HIV space, whether you're HIV positive or whether you're HIV negative. So some of those kits are under validation right now. And I think some probably might have found their way into the markets already because probably validation has been done elsewhere and those have been documented. And so these are totally different from the earlier lamb kits that were available. So yes and no. So probably the original lamb kits that came into place, they were targeting HIV positive individuals. That's correct. And that's why they even stated that they wanted individuals who had a CD4. First of all, they started with CD4 below 200. And in my presentation, you've seen CD4 below 100. But right now, their kits, I didn't mention it here because the one we are doing, we haven't validated and, all those procedures haven't been done. So there are those kits, lamb kits that are coming out that will be able to go across whether you're HIV positive or HIV negative. And then there was this question of pasteurized milk. This is a great question. There's a study that we did where we were looking at TB transmission from mother to child, right? And we were enrolling a pregnant mother that was soon to deliver that had TB. And therefore, we were also having some of the breast milk, not all of it, but some of the breast milk that we were detecting TB in them. Very interesting study. And so I may not say that when you drink unpasteurized milk, then you may have TB. I will put some people out of the market. But I think we want to believe that transmission of disease can happen if and when samples such as milk or any other which is contaminated, and I want to emphasize that, which are contaminated are mishandled or not handled properly towards prevention of whatever infection that they carry. We know MTB complex, which also contains MTB bovis and for the TB1. Those could be like brothers, which forms the complex, then therefore that may be able to transmit TB. But I have not done research. Maybe it's out there for the person who raised the question. I have not done a research, probably it's out there, but I've not done research on pasteurized milk and TB. Probably some area that we may need to consider. But any specimen that is contagious or infectious and mishandled from one point to another, then the likelihood of transmission would be there. Then somebody also wanted to know about sensitivities of lamb. This is a problem, and I think there was a time that there was a hue cry that all patients that were done lamb were positive and what have you. And I think lamb sensitivity would be between 70, 80, depending on which of the lambs you've used. But I think the range, I would give it as a range. Sensitivity will be 70, 80, probably 85 or 88. And specificity probably is a little bit higher. I'll give it between 80 to 90 or thereabouts for the lambs. I think I touched on virtually those questions. Back to you, Fred.
Very well, Dr. Very well. And maybe just to add something, there's an outlier from Tyrus Omondi. In terms of genetic diversities, is there a difference between zoonotic TB and human TB isolates? Can the INR or rifampicin be useful in zoonotic TB? Okay.
But fantastic question. Thanks, Dr. Tyrus. I think this is a very great question. Yeah, come to think of it, this is an area that I think we need to focus on probably and do research on. I may not say yes or no, because if I culture Microbacterium tuberculosis bovis and then I do a DST on isoniazid and rifampicin, I will be able to get this feedback. So thank you, Dr. Tyrus. This is an area that I'm picking that I'll be able to see how in the next environment, we should be able to get a feedback out of this. Thank you. Back to you, Fred.
Thank you so much, Doc. And maybe I get back a couple of more questions. I'll start from, okay, Kenneth Okubo. Is it possible to diagnose MDR in routine labs? And why is culture for TB only done in a few focal labs? So maybe I'll add a few more questions. Doc, you can note that. This is an anonymous attendee. Does the MDR TB patient transmit the MDR forms? Maybe we can take those two.
Correct. Yeah. So MDR TB, can it be done in routine labs? Great question. So I think it depends on what techniques that you want to employ to detect MDR TB, because I listed a couple of those. Even molecular diagnostics can do MDR TB. And the molecular diagnostics that I didn't mention were gene expert use, line probe assay. If you have a capacity to do the PCR tests in routine, then you can be able to do it. However, I'm putting the word however, that we need to consider, which is of great importance, biosafety biological safety and hazard management of those routine labs, because the moment you start manipulating specimens that are potentially hazardous with microbacteria, then you're handling a biological weapon. So depending on the routine lab, if you want to do those tests, you must have systems in place to be able to handle biosafety requirements to run those. And I think the country did try and implement a mini, if you, a semi, not mini, but a semi MDR diagnostic labs in about 5 or so facilities outside of Nairobi and Kisumu. I know there was a semi MDR diagnostic lab in Kitale. Probably the Kitale people will tell me if they are on here. Then there was one in Machakos. They should have one in Machakos. Then there should be one, was it Kilifi or Malindi? One of those. And then there should have been one in Busia. Those are the ones that are coming to mind. Probably attendees, if they're here from those facilities, may be able to say whether they have them. But it's important to consider biosafety management. And two, culture is very expensive to set up, and that's why they have focal labs. Setting up culture lab requires enormous resources because you are going to create or develop a lab akin to a theater where you are going to have an entire room for the culture having a negative pressure 24/7, right? So I wonder which routine facility in our country will be able to sustain that. So you'll have a negative pressure room where you're going to manipulate your specimens for culture 24 hours, 7 days a week, 365 days a year. Back to you, Fred.
Very well, Dr. I can read a couple more. So I'll start with Kenneth Okubo. Okay, so maybe I can read this from Benedict Washala. How much will it cost to treat one MDR-TB patient in Kenyan shillings, despite receiving them as donations from developed countries? Again, why is this MDR-TB still high in developed countries like China, Russia, and Europe? Because we expect them to be at low rates due to the advanced technologies. Could it be because of the high population, especially in China? Any insights?
Great question. I'd be lying if I can say from my head how much it costs to treat MDR-TB. But the last time I checked, I think it was costing close to between 2 million, between over 2 million to treat one case of an MDR-TB to completion, right from start to finish, around 2 million. But I can be able to check this and probably share with you. But I think that was the last time I did find out how much it costs. It's quite expensive, despite it's rightfully states, despite the support that we get from multinational donors and the global health and all teams. So that's a great question. I should be able to find out that. And then, yes, that question for why China, Asia, I think this may boil down to population, as you rightly state. It could play a role, because even previously we used to, and even still now, we do say that TB spreads when there's in areas where there are a lot of population. I would say so, like for example in slum areas, and even in Magare, in probably Nyalenda, Kisumu, Obunga, Manyata, those places that there's a huge population. There's likely a population, and then the environment is not conducive. So population does play a role in the TB spread. And rightfully say that despite their technological advancement and everything, I think population does play a very, very big role in terms of population of TB spread. And many of the studies that we have done in the past we have been engaging in multi-sites where we have similar studies being done in Kenya, also done in those countries which have also high population and high TB cases. If there are other reasons, probably that population could be one of them. Back to you, Fred.
Thank you. I'll take from Kenneth again. There was a TB Manyata in Isiolo where TB patients were quarantined. Does such isolation help reduce the TB burden or not? And if it does, can such isolation centers be put up in all counties with high MDR incidences? And then I'll add another question from Comfort Nyando. Kindly clarify diagnosis of TB on biopsy. You can take those, Doc.
Okay. Great question on TB Manyata. And this, this we have had tremendous discussions all over. And, you know, Kenya is a democratic country, and Kenya also, as being a democratic country, has a lot of human rights issues and human rights advocates, and a lot of that. So from some quarters, it is viewed that when you isolate individuals, you're denying them their human rights. And if there are human rights bodies here, they will tell you that no, you can manage them within the population. So the Manyatas have been in existence, and I think many, you could still find some existing even now. I'm not so sure whether they were all wound up, but I think the issue of putting them separately has caused a lot of ruffle some feathers around the human rights and protection and everything. So yeah, that is no longer practiced by all. There could be a few more, but I think that is no longer being practiced. And I think it's not being encouraged because of human rights aspect. Now, the other question was, Fred, remind me again, the last one.
Biopsy, I think.
Oh, yes, yeah, biopsy. Yeah, there's a study that we did with about human about biopsies in humans, and I think we were supporting a study from KNH at the time. They were having lungs of individuals suspected, pieces of lungs of individuals suspected to have TB sent to a lab, and we were doing so. We were using expert and culture to do that. So you can use biopsies. You can use biopsies to detect TB if they have TB. Only that there are methodologies that you must employ in the laboratory procedures of preparing the specimens for testing.
Thank you, Doc. I think there is a concern here. I've seen quite a number of us have raised the concern. I think regarding the unpublished study, and maybe I can just read the verbatim from Mohammed Mustafa. Your presentation highlighted the significant cost efficiencies achieved through pooling in gene experts, which we commend. However, we are considering a potential drawback, the risk of false negative results. This concern arises from the possibility of diluting samples, particularly those with low bacterial load density. Could you elaborate on your perspective regarding this trade-off? And I think it's a concern that I've also read from a few of you. So maybe Daktari, anything?
Yes. That's a great concern, because I know we are concerned with sample reagent ratio. We always know 2 to 1, 1 to 2, depending on how you want to look at it. And then homogeneity of the specimens that are coming to, for the study that we did, which then, provides this information. All the specimens were split into 2 after homogeneity. So all the specimens were split into 2 after homogeneity. And the 4 specimens that we took, and put into 1 cartridge, the same specimen we cultured. The same specimen we cultured, and also the same specimen we did, because it was a study. It's not routine. We cultured, and we also did an expert again on the side. So that comparison is what I'm talking about. So if I did 4, put in one cartridge, the same 4 that I put in one cartridge, each one of them had a culture done, and each one of them had another expert done. And the congruency of the outcome was 98% of all the outcomes. So it's something that, so we took care of potential issues arising out of, specimen that we are going to mix. How do you, mix them? Then how much do you take this? Or if the specimen is not homogeneously enough, you might end up picking an area that doesn't have bacillary load or what. So we took care of that insofar as the study was concerned. So yes, there was congruency in what we did, close to 99%. I don't know whether I responded to that, Fred.
Yeah, very well, very well. Yeah, thank you so much, Tim. I can see people from this should be Mandera County Teaching and Referral Hospital. Abdi Abdo says that TB Manyata still exists, only that the number of patients has reduced over time. And then I've also seen someone commenting on the cost, the current cost at 1.5 million. That's from Jacqueline Limon. Also, Jeremiah Ndeto, we acknowledge your feedback. You say that TB culture requires a P3 lab setup for handling culture, whereby its setting up and maintenance cost of the same is very high. So I really appreciate your feedback, Tim. And maybe, Dr. Seeing time is fast moving, but we can get more questions. And this will be from, okay. I'm seeing some are repeating. So I think this is a very basic one. Maybe it's fast. Maybe you can just repeat it for clarity. What's the gold standard test for diagnosis of TB? You can just have it, and then maybe I can read some more.
Yeah, gold standard for TB testing is culture.
Sure. And then can read this from. Okay, there are many questions, but let me just see the ones that we can pull again. Mike Osita, great presentation. Looking at the trends of TB infections over the years in Kenya, can we attribute the increasing trends to intensify diagnosis rather than increase incidences? Thank you, Mike. And then I can bring in Benta Anam. What are the current gaps in TB vaccine development? And how close are we to an effective adult TB vaccine? Then I can read the final one from, okay, this is from Nyamoya Collins. Do we have rapid test kits in production to detect TB? I think just the same question. Faris Okot, what is the worst that can happen when you do TB lab for patients who do not meet the WHO selection criteria? Thank you. Doc, you can start.
Sure. Yeah. I like the other question also. These questions are very nice. Let me start with the incidents. That's a great question. And I think it's a nice observation that she has made there, that yes, the country has really, the TB program has really intensified case finding. And probably that's why we could say there are many cases, rather than the disease increasing, probably. Or the case finding has been done, and probably the cases that we were not finding, we are now finding them. Most oftentimes, you used to find patients who are having TB coming to hospital when you could call them late. And when you do the smears, they are +3, 3 pluses and above. So they are very advanced in disease. But now when you do intensive case findings, then you can help somebody with a 1+ and everything. So it means you're going all out to get people who are sick. So it could be both. It could be both. Maybe because of the intensified case finding, that's why the trends are going up. Or there could be many people out there. The disease is spreading. And therefore, as you do intensive case, you bring as many people into the fold. So that could be a possibility. Then the question about vaccine development, thank you for this question. And I know many vaccine trials have been done over the year, and I think we are at a certain stage of vaccine development for adults. I may not exactly state where we are at in terms of nearly getting one there, but there are certain good improvements that have come out of a more recent vaccine trial that is ongoing. And I think both the IRVs and the GSK, they are the ones leading in vaccine development. I think they are at certain levels of vaccine development. I may not give as much information about vaccine development because I didn't research on that, but I think this is some area that if needed, we can be able to talk about it at a different time. And then the other question on rapid test. Yes, there is a rapid test that is coming out. Maybe not rapid as you want to see it on a card like urine lab and what have you, but there's a rapid test that is going to come where you just swab your mouth, swab people's mouth, and then the swab that you swab their mouth, you dip them into certain reagents, and then you do a test with them. So there's a study that we are almost mounting that will be able to look at that as well. And I think there are many other rapid tests that are coming out. I may not point them out, all of them, but just we should be in the know that the tests are coming out. Again, about TB lamb for people who are not HIV and everything. So you can have TB lamb, performed on individuals. Like I said, I may not tell you that don't perform it on HIV negative, because depending on the generation that you are going to test, whether it's the TB lamb 4th generation or the 1st generation or 3rd or 2nd, like the generation that we're working out with right now, we are looking at testing TB on individuals regardless of their HIV status. So depending on which one you have, you may be able to identify and know that the one I have can only do for HIV positive individuals, but this other generation, and they will be indicating them on the kits, on the inserts, and you'll be able to know this is a generation that is able to pass, cut across the rest of the HIV status. Anything that I left out of that? I think I got them all. Back to you, Fred.
Thank you so much. I think someone has also commented, Jeremiah Ndeto is saying, currently we have a clinical trial at Cambridge CRDR for a vaccine that will replace the BCG if its efficacy is up to the required standards. So, but I just want to read in, should be a concern and maybe a comment from, I think this should be our last one because of time. Brian Kipkoske. I once came across a client, a HIV positive, diabetic, non-alcoholic. He had history of TB. He was treated and treatment completed. 1 year later, he came with symptoms of TB. He was bacteriologically confirmed through GeneXpert. 2 years later, he was back. This time round, he was diagnosed with MDR TB. Culture was done. Client initiated on treatment. He was on treatment up to month 2, going to 3, when he succumbed. My question is, what might we have missed on the management of this client? So, Doc, I'll add another one. Just note that. I think there was another concern. I can't quite have it on the use of masks. And I think someone was saying that it is discouraged, and what should they do where in setups that they don't have a biosafety cabinet. And then the final one, I can't read it verbatim also. I think there was a concern on those who are caregivers to those who have been diagnosed with MDR-TB, on maybe how long does it take to be cleared or something. I think that was the exact question. So, Doc, maybe you can just see how to respond to that.
Okay. Yeah, so my apologies to the person who lost the life because of TB. Yes, and I think this is the direction that the TB program, I may not speak on behalf of TB program because I'm not capable of that, but I know there's an algorithm change that has been has been occasioned because of similar occurrences. When an individual has been tested with gene expert and there's rifampicin resistance, the algorithm requires that their laboratory diagnostic must be done for both first line and second line together, so that we are able to cover for the patient not going to the first line treatment, but also taking care of the second line, so that we know which level of treatment or care this patient might so require. So that's one way of looking at it. Number two, I may also not cast aspersions on the management that was given before the patient was considered to go for MDR testing. But I think we know that we should put patients on treatment and then follow through, intensive phase, then the follow-up period as required, then term people cured or treated, and then do that and that. So when a patient who has that history that you've mentioned that went and was deemed cured, depending on what treatment regime that they had, if and when they came back together, then that would be an indication for having to go full throttle in terms of identifying what could have been the problem. And that kind of patient would have benefited without going through another round before another round of management. So right now, if somebody turns out to be MDR resistant based on, or rifampicin resistant based on gene expert or whichever methodology, line probation and everything, the program requires that they are done for testing for both first and second immediately at the same time, to be able to know how are we going to, what are we dealing with, and how are we going to manage that. And then the other question, how long does TB take to clear? I think this is just the treatment that we're talking about. So if it's just a normal TB, which you're treated with the 4 drugs that I said, rifampicin, isoniazid, thimerosal, or pyrazinamide, I think treatment, I think is, Jackie Limo, if she's here, she will respond on the chat, but I think should be between 6 months, 6 months or thereabouts. I want to believe. But if it's MDR TB, that's a different ballgame. Could be between 9 to 12 months. And if it's XDR, that's a different ballgame as well. So it depends on the kind of TB that this individual does have. Will determine how long that you treat them. And when you say that they're cured, then we believe that they have cleared, the TB has cleared in terms of the bacilli organisms in the body of these particular individuals. Then lastly, how do you handle biosafety or safety issues? Yes, for most part of it, if you're not handling and manipulating specimens, like in a culture facility and everything, you should be fine. And also, we are told that infection with TB depends on the bacillary load, the volume of specimens you're handling day to day. If you're handling more than 100 samples every day and you don't have a biosafety cabinet, that is a problem. But if you're handling like 1 or 2 in a day in an environment, I would say if you're handling between 1 to 5 or 1 to 10 max in a day, then you're okay. But if you're handling beyond 20 upwards, then there's a concern there. There's a genuine concern there that you need to consider safety requirements. And safety requirements does not necessarily mean that you have to have a safety cabinet. If you can, fair enough. If you can have a hood, fair enough. If you can now ensure that you change the room that you're doing your TB and increase air circulation and everything that is required, fair enough. Put on masks, all that kind of stuff. Like you say, your masks are not allowed, so you find out what is the better option. But I would be careful to say that handling more than 50 and above in an environment that does not have a hood, that will be risky. If you do that every day, that would be risky. That will definitely be risky. Back to you, Fred.
Great. Excellent, Dr. Albert and team here. I think it has been a very wonderful presentation, and you can see that it has elicited a lot of comments and concerns, and We want to say that we have noted, and maybe we can arrange for further engagement regarding this area. And maybe on behalf of everyone who attended, we want to say thank you. I want to invite Daktari to give his closing remarks, and then we can give our closing remarks.
So thank you so much, Fred. It was a pleasure and honor to be with everyone today and share this wonderful topic. Like I said, very interesting topic, and just learn what else we can, do to support our country and by extension, our families, our people, to be able to work towards eradicating TB by the end of 2035, as it's part of the end of TB strategy. In our various ways, from where we work, that bench that we sit, that lab that we go to each and every time we work, and the space that we have is given to us by God to be able to be a helper to the humanity and serve humanity. So if we look at it from that perspective, I think we would be able to do a great job in our country and even to ourselves, because today I may be treating somebody sick in Nairobi, but my parents are at home. Somebody else will be taking care of them as well. So thank you so much for this wonderful opportunity, and looking forward to another opportunity if it does avail himself for another interesting and valuable topic. And wishing everybody a pleasant evening. Over to you, back to you, Fred.
Thank you so much, Daktari. And to everyone who managed to join, I've seen your concerns regarding you need the presentation, and you sent many emails. So I just want to advise you that we were, many of us here, I think 2,000 plus. So it may not be very possible to share, but I would encourage you to get into our WhatsApp groups. Also, I have shared the link to our YouTube. The presentation was live there. You can always go back there and just follow it up for your own reference and for your own benefit. So you can just go to YouTube, look at and search Lab Medicine Society of Kenya. The presentation was live there. You can always follow. Otherwise, on behalf of Lab Medicine Society of Kenya, to you, Dr. Albert, we want to say thank you so much. And we look forward to another session or another time that we will also be able to discuss these important topics that relate to us and even to the laboratory division in the country. Otherwise, to all the participants who managed to join in, we want to thank you, send you your certificates, and also for those who are for those who have KMLTB numbers, we shall be able to upload the CPDs for you by tomorrow within 24 hours. Otherwise, thank you so much and see you next time. Thank you.